Hi everyone, my name is Catherine Hardy. I'm a midwife and I currently work as the local maternity systems programme lead for the North East. I've been asked to make this video today to discuss continuity of carer, my experience of working in this way and how you can get involved with our current work. Firstly, let's take you back to the 90s. Continuity of carer was one of the main themes within change in childbirth in the 90s. That and giving women choice and control of their care. Which is very similar to today. My community midwifery post was enabled due to what they described as pump prime monies. We were tasked to introduce continuity of carer into North Shields, and we were a team of motivated individuals, 5 of us, and we really wanted this to work. We were fed up with how we were working in the hospital and really wanted to make a difference in a deprived, low socioeconomic community. You may well remember it was where the Meadowell riots happened as well, so it was pretty deprived when we started working there. So initially we thought it would be like this. However, due to a number of different reasons, it soon felt like that. And what we found was we had very little work-life balance. We felt our family life came second to our work life, and we felt a real obligation and responsibility to the women that we cared for, because we were promising a service where we would be there to meet them, but it wasn't working out in that way. So we became stressed and burnt out quite quickly. Why was that? There was a number of different reasons why that was. The problems were that our caseloads were too big. Mine was 198 women to look after. I know it sounds ridiculous now, but at the time, you know, you're just trying to implement this new way of work and you wanted it to work. You thought, right, we'll give it a go. Everyone else's was between 100 and 200. So the caseloads were far too big. Plus, the team wasn't the correct size on reflection. You know, there was always somebody on holiday doing some training, etc. So it became the on-call rota turned out to be too onerous and unsustainable. There was no flexibility regarding a 37.5-hour week. And what I mean by that was, if you weren't called out, you had to make up the hours that week, rather than taking it over a 4 to 6 week period, because another week you would work double 37.5 hours. There wasn't any project management support either. We were asked to introduce this, implement it ourselves, which at first felt great because we felt empowered, but soon we realised that without support from the broader system, hospital colleagues and management, etc., there was a disconnect, a lack of understanding, almost animosity at some times, because we were perceived as coming in and delivering the baby while people had looked after them for a little while beforehand. So I think, again, you would never introduce anything like this on this scale, how we did that in the 90s. It just added to the stress and our becoming disheartened as the weeks went by. So why are we doing it again? Why are we trying to implement continuity again when it didn't work in the 90s? But it didn't work because of those reasons. And there was a Cochrane review in 2016 done by Sandel, which provided vital evidence, reliable as well, regarding the benefits of continuity of care for women and the advantages it can have. This is achieved by the relationship aspect of this piece of work. So the Cochrane review found that women were 16% less likely to lose their infants, 19% less loss of babies before 24 weeks, 15% less use of regional anaesthetic, 24% less preterm births, 16% less episiotomies, and 10% less likely to have an instrumental if continuity of carer was implemented. And how can that be? And all the evidence points to this relationship that's built up with the women. And I can vouch for that, the feeling that you're really making a difference for those individual family, because there's a perception of safety around you. The relationship is a mutual trust. You get to know the lady. There's a mutual respect. and she'll listen to what you're saying. So you can devise individual education for that family, whatever they need, and counselling and referrals on. So you look after her, she becomes known to you, and the midwife is trusted. So you find that they will listen to you when it comes to smoking cessation much more readily, and go and find help and get some support to stop, which gives that pregnancy a greater start in life. So introducing this across the northeastern Cumbria will have a positive impact. And here's some stats on regarding how that might be from the analysis undertaken at Cochrane. Across the northeastern Cumbria, we have approximately 31,000 births per year. And if continuity of care is introduced, we would see 550 fewer preterm births and more than 700 spontaneous vaginal deliveries. And I think we have an obligation to introduce this within our area, because the evidence is so strong that it makes this benefit to women. So you end up with a healthy baby, a happy baby, a more satisfied mother, and not only that, a much more satisfied midwife. And again, working in those ways certainly helped us in the North Shields area. So we have learned from the 90s and what that was like, and we are determined to do things differently. This time it's all about having small teams of 4 to 8 midwives with caseloads of 30 to 40 women, and we want to make sure that that happens so that this is a sustainable new way of working. Given the ownership to the staff on the shop floor, because that's the ones that are going to make this work. And if you don't feel part of that undertaking, then it's going to be felt as if it's forced upon you rather than you being part of the resolution. We have started this amazing regional project that has to be undertaken so that we can support large-scale transformation. And I want to extend that invitation out to everyone to be part of this. So provider trusts are working on their own projects to introduce continuity, which we need to achieve 35% of women booked on a pathway by March next year. We've also been working across the Northeast with all providers to look at this important piece of work. What would it be like to provide continuity to all pregnant women? It's interesting because our initial findings are certainly demonstrating that we need more support for midwives so that they can be relieved to provide midwifery care properly and free up time to introduce the intrapartum element of care. And our findings are being used as a lever to inform the directors of nursing and the integrated care system of what it may take to sustain this care pathway moving forward. We've had transformation funding to be able to support some local initiatives like the role of continuity of carer lead, and also the transformation plans that have started already. Some projects are further on than others, but we are supporting moving forward to get to that 35% and more. Whether someone has received continuity of carer is part of the CQC maternal satisfaction survey going forward. So they're going to be asked whether they had or they knew the person that delivered them. It's also included in the data collection within each trust called the Maternity Services Data Set version 2, MSDS. That it's mandatory to capture MSDS data, which now includes whether the woman received continuity of carer. So we'll be able to have this triangulation of evidence which says the woman thinks, she agrees, she got continuity, knew the person. It clarifies that within the hospital data set, and then we'll look at what the outcomes were for that woman. And things are happening along those lines already. When I say that the need to deliver continuity of care is contained within the standard contract, that is an expectation from the clinical commissioning groups that it becomes part of everyday service within maternity. So again, it is absolutely imperative that we work towards this end goal. It's not going away. We need to focus on the vulnerable in our society because they have definitely benefited much more from continuity of carer. And we've learned lessons from 1993. And because I know what it was like in the 90s, this is why I can inform the work going forward to say, well, we need to think about the size of caseloads. We need to make sure those caseloads don't creep up as this moves forward, because it will burn the midwives and stress them out. So we need to work together. We need to support each other. We need to design a system that works for us, reducing the unnecessary waste, manage midwifery time more efficiently, work with our obstetric colleagues, work with the directors of nursing, and in the future consider cross-boundary working for women who live in an area but decide to deliver elsewhere. We should be following the woman rather than the woman just going and say, well, if I lived somewhere else, I would get continuity. With the Royal College of Midwives is involved in every aspect of our care to make sure that the midwifery side is supported, and that is so important to our current work. I can't emphasise that it's about the midwifery element as much as it's important to the woman. We are encouraging you to get involved, because there's so much going on out of the unit that will help and support you who are transforming women. You're the ones transforming women's care, and we are here to support you moving forward. I think the evidence speaks for itself. It's so important to provide this care for women. It will make a difference to their care and that of their babies. We've got an obligation to do that. Every other aspect of our practice is regarding evidence-based care. The evidence is here for continuity of carer, and I wish you all the best in your endeavours. Thank you and good luck with this vital piece of work.
Hello, my name is Lucy Findlay, and I'm the Continuity of Care Lead for the South Tees NHS Foundation Trust, which incorporates both James Cook Hospital in Middlesbrough and our standalone midwifery-led unit at the Friarage Maternity Centre in Northallerton. I would just like to share with you some of the ideas and projects that we've been putting into place in our trust for the Continuity of Care project. Things are well underway with the launch of our first 3 teams, both here at James Cook and in the Northallerton Friarage area. So at James Cook we've been looking at high dependency, vulnerable women and families, and we have done a lot of work with trying to find out which area of our catchment area in Teesside will be most beneficial to have continuity of care as our very first continuity of care team. So we have found an area that, although very mixed risk with families from a lot of different backgrounds, it's a geographical area that has some pockets of deprivation, poverty, some of the highest teenage pregnancy rates, and some of the highest smoking and pregnancy rates, highest obesity rates, and some real pockets of mental health problems with families and women there as well. So that's where we've decided to focus our efforts with our very first team at James Cook, which are going to be called the Primrose team. So this is a team of 8 midwives who are very passionate about providing continuity of care throughout the whole of the pregnancy journey, from booking at 8 weeks right through antenatal care, intrapartum care, and back out into postnatal care in the community, following through to discharge to the health visitor. So that team is going live on the 26th of October. We've already got the team all trained. They're all ready to go. They were ready to go in April, but through the summer have had to be back in their usual roles, and now we're very excited to get started in October. We've also linked in with lots of external agencies from the community, from the council, and from standalone agencies such as mental health, IAP, smoking, Slimming World, there's financial services, housing and benefits advice, and we're going to put ourselves all together in one hub right in the centre of the geographical area, so that women and families can access those services all under one roof in one place whilst they come to see the midwife. So we really think that some of those benefits, not just about maternity but the whole pregnancy journey for both the women and the other children and the partner and the rest of the family, we can really start to get those benefits through. So we're really excited about starting our very first continuity of care team at James Cook for the full pregnancy pathway. So that's going to cover about 370 women. Obviously we want to get more and more women into continuity pathways, and we're hoping that that first pathway, that first team, will influence our wider workforce to want to be part of these teams. Of course it needs to work for midwives as well as women, and the midwives in the Primrose team are the very first midwives to be on a fully flexible rota. They're self-rostered and completely in charge of their own, managing their own diaries. So some are working split shifts, some are starting a bit later, some are finishing later, some are doing less hours one week and catching up the next week when they might have more childcare and things like that. So it's fully flexible around the needs of the midwife as well as the women. We are hoping with this team to cover our birth centre in high dependency and low dependency at James Cook 24/7 by using a rotated night shift midwife and an on-call midwife during the day from the team. So there will always be somebody available to the unit 24 hours a day, 7 days a week to care for the women in that team. We also hope to offer early labour assessment at home, which will reduce footfall into our maternity assessment unit at James Cook, and also provide those continuity of care team midwives to come in to be women's advocate at the consultant-led clinics in the antenatal clinics for our high dependency women. So we're really looking forward to seeing how that works, learning from those experiences, and then being able to roll out our next continuity of care team at James Cook. Over in our maternity-led unit at the Friarage Hospital, we are also just put out expressions of interest for 2 teams over there to lead on our low dependency women. So every low dependency woman in the Friarage Northallerton catchment area, which is about 500 women a year, they will be booked and cared for the same as the Primrose team throughout, from booking through interpartum care and postnatally, by the same group of 8 midwives. So we're going to have 2 teams over there, and one of those teams is going to be specifically looking at our military families, which are based in Catterick Garrison. So again, that's a very mixed risk, but a lot of those families suffer from isolation. There's pockets of poverty over there, and there's some women over there from forces from abroad, so some non-English speakers and some that are very isolated from their own families abroad. So we really are focused on vulnerabilities with these first three teams, looking at our low dependency birth centre care as well, hoping to roll that out to more high dependency women over in Northallerton over the coming months. And then for our 4th team, which will be our second at James Cook, we are going to be starting to do a lot of work on BAME families and the inequalities in healthcare, and seeing where we can really help to bring some of the benefits of continuity to those families in our area. So there's loads of it going on. We're absolutely back with a vengeance after all of our COVID restrictions and different ways of working, but all of the midwives at James Cook and at the Friarage across South Tees are really excited to start to be getting continuity of care back on the agenda in such a positive way with our new teams. So looking forward to hearing what you're all up to. Thank you. Bye.
Hi, my name's Amy Matthews, and I am the Continuity of Care Team Lead and Project Manager for County Durham and Dalton Foundation Trust. We have lots of plans for our continuity, but as yet it's still not off the ground with our first team. However, we are going to be launching our first team, who will be known as the Infinity Team, within the area of Stanley on the 2nd of November. That team consists of 4 midwives, a maternity support worker and myself, with the aim at providing antenatal, intrapartum and postnatal care for the women booked onto the continuity of care pathway within that area. We're looking to have caseloads of no more than 36 in line with better births and recommendations, and we're looking at covering 24/7 with on-call rotas for that. So looking forward to that starting. We've got some very keen midwives on board who are really looking forward to building up those relationships with the women and hopefully getting some better birth outcomes for those ladies. Within our transformation paper for CDDFT, we also have lots of other plans to how to incorporate continuity down other pathways. The first one we're going to be looking at is the Black and ethnic minority groups. Our plans to integrate a pathway of care specifically around continuity for those ladies will include one named midwife from each existing community team to provide continuity of care through antenatal, intrapartum and postnatal care for those ladies, looked after in a very bespoke way and offering lots of different opportunities that probably they haven't really had before with regards to interpretation for birth classes, also for breastfeeding support. So looking to improve the outcomes massively for those ladies as well. The other part of our transformation is looking at a separate home birth team. So we will look again to have one named midwife from our existing community teams to formulate part of a home birth team. Any ladies who are wishing to have a home birth, and we're looking at promoting this because obviously we want to improve our home birth rates, which currently sit at 1%, so not great. But any ladies who wish to have a home birth who are low risk midwifery-led care will be placed on the continuity home birth team pathway before 28 weeks, and they will be looked after predominantly by the midwives within the home birth team and with the look at delivering those ladies at home as well. Again, using an on-call rota which will incorporate some of the existing community teams. Our plans going forward are we have a wave of midwives coming from the acute setting to fill in the gaps in our rotas with community, because up until now we've been very highly understaffed within the community. So first and foremost, getting our teams up to a safe level of staffing, and then there will be another wave of midwives from the acute who will be placed into the community teams to expand the teams in order to facilitate this from January, end of January, beginning of February. This approach obviously is very exciting. We're going to have a lot of the community teams expanding to the point where the caseloads will hopefully reduce significantly, and eventually we'll be able to formulate part of the expansion of continuity within our trust.
Hi, I'm Jane Harker, Regional Officer for the Royal College of Midwives in the North East and North Cumbria, and one of the maternity units that I cover is the RVI. I want to talk to you today about continuity of carer. The RCM recognises that continuity of carer is the central model of maternity care that should be rolled out across the UK for women. We also recognise that there's a raft of evidence that supports the positive impact that continuity of carer has on outcomes for women and babies. We've produced lots of information regarding continuity of carer, and that's available for everybody. You don't have to be an RCM member on the RCM website. Click onto the website, click the promoting tab and go down to continuity of carer, and all of that information will be there. Nationally, we've also produced a list of conditions that we feel need to be in place to support workers, and they are the right conditions for in your workplace, and that involves early engagement with staff, discussing continuity of carer, that there should be a ring-fenced investment for things like staff training, provision of the right equipment, and also the right physical environments for continuity of carer to work. There should be safe staffing levels, and these need to be introduced before continuity of carer is. There is now a birth rate plus continuity of carer bolt-on, and we're asking that maternity units complete that so that they have the right staffing levels that also include the continuity of carer teams. We have advice around how many caseloads that women should be held by midwives for a year, and also the number of midwives that should be and in a team as well. There should be flexibility for staff to self-manage and develop their own working patterns, and most importantly, there should be protection of your working conditions and also your home-life balance. So that means that the Working Time Directive has to be taken notice of and followed as it is in your job now. You also need to have followed the national terms and conditions for NHS workers, And you may know that as the Agenda for Change guidance, and that needs to be implemented fully. You need to have your protected time off, and that includes not having on-calls into your days off or doing on-calls on nights before your days off as well. Continuity of care needs to be a co-production between maternity staff, staff side representatives and service users, and there needs to be a full evaluation of that as well for it to work properly, and that should involve staff side representatives. Good luck with your day. You have no idea how many times I've had to do this video for it to work, so I hope you've enjoyed it.
Hello, my name is Anita Scott and I'm the Specialist Lead Midwife for Continuity of Carer with North Tees and Hartlepool NHS Trust. My interest is looking into how women can have the same midwife throughout their whole of their pregnancy journey, and that pregnancy journey starts from the very beginning. So as soon as you find out you're pregnant, we want you to fill on a simple online form which is on the North Tees and Hartlepool social media pages and web page. It's a very simple form. It takes about 10 minutes to do. You'll need your height and weight before you complete it, but then we will contact you with an appointment with your midwife who will be performing your care throughout your pregnancy journey. Continuity of carer is really important. It builds a good relationship with your community midwife so that they know the things that are special to you and your family. It reduces the risk of premature birth, reduces the risk of the need for things like an epidural in your labour, and also reduces things like episiotomies. You have more chance of having a normal birth with a continuity of carer pathway.
Hi everybody, I'm Tracey Cooper. I'm the new Regional Chief Midwife for the North Eastern Yorkshire, and I'm really proud to be working with you all. I'm so excited. I really want to come and visit you as soon as possible up at Newcastle, just to see that the work you're doing and to have a look at your units and everything, and provide some support. I just want to talk to you a little bit about continuity of carer and why it's important. We know through the evidence that women get better outcomes for themselves and for their babies, and that's what we want to do. We want to create better, safer care, and we want women to have the best experiences possible, and their families too. We know that continuity of carer models are really hard to implement because it's a whole culture shift and a workforce change, and it is extremely challenging, but we know the benefits are worth it. So come with us on this journey. You're doing great so far, and we know you've got really good plans for the future.
Midwives, you already do a fantastic job. And the studies of North East women that show that between 75 and 80% of women said that they felt listened to and had a high level of care from their maternity team. We know that continuity of carer can improve parents' experience ratings even further, and again the women of the North East demonstrate this. 80% of North East women believe that knowing the midwife throughout their pregnancy, birth and postnatally will improve their maternity experience even further. Midwives, you already do a fantastic job. Continuity of carer means you can improve even more how women and families feel about their pregnancy and births. Women and their partners want to know you. They want to know their midwife. Don't just be our midwife, be their midwife. Be my midwife.
Hello, my name is Tracey. I'm the National Midwifery Lead for Continuity of Carer, and I'm very excited to be able to talk to you through this little video. It's my first attempt, so I hope you'll all smile back at me. Hello, Newcastle. This is who I'm talking to today, and I hear from Mel, your Better Birth Lead, that you are all getting geared up to roll out your continuity of carer programs, and I can't tell you how exciting that is. Our world seems really broken at the moment, don't you think, with our pandemic and with the recession and with the environmental concerns and so many different things that cause us concern. And yet, as midwives, we're in a position to make a huge difference to people, to women and their families and to babies. And you know, I wouldn't want to be in a different profession, even if you paid me lots more money. So what do I mean? Why do midwives make a difference in this situation? Why is continuity of care so important in that method of changing the world that I've mentioned? Well, we do two things. One is, of course, as we all understand, we change the short-term outcomes for mothers and babies. So by caring for women within teams of 8 or less and caring for 36 women, we are much more sure in providing a better short-term outcome, such as preventing prematurity, preventing baby loss, preventing other interventions, and therefore making a mother's childbirth experience much, much safer in the short term. But the other thing that we often forget is that we're changing long-term outcomes for mothers and babies. So when that mother and baby dyad are healthy, what happens is we change that baby's life chances as it grows up. So, for example, a mother and baby that are healthy, the child is then born, and then 60 years later comes out and it doesn't drop dead of a heart attack. It doesn't die prematurely because of not being healthy from the birth perspective. We know that cardiac disease, for example, has its origins while the baby is still in utero. So from that perspective, we make a huge difference. The other thing that I think we make a huge difference to is that in giving that therapeutic relational care within a manageable group of women, such as 36 women, we help a woman not be depressed, we help a woman not be anxious, and therefore when her baby is born, she's far more likely to breastfeed, and she is more likely to read to her child and speak with her child as it's still a baby. And doing those things means that that child will be ready to go to school. As it goes to school, it will be ready to flourish and ready to learn, and therefore it won't be labelled as a problem child, and then that child will go on and do well in life and go to university, get a job. So we're also impacting the cycle of poverty and cycles of deprivation and all those health inequalities that we're talking about so much at the moment. But we don't only do that. As we change our models of care and as we start to give care through continuity of carer, we actually make life much, much better for midwives. So as we know from the WELM study and from the NHS various surveys that have been coming out, midwives aren't very happy in their work, and that's completely understandable. During COVID, I myself was working clinically and I could see exactly what the problems are. It's lovely giving care to one woman and you're focusing on her and you can have a really lovely time. But then when you're asked to do that 2, 3, 4 times over and over again, you're already emotionally and physically spent with the first woman. How do you find time to care for anybody else? In working in this model where you're only looking after 36 women over the year and you're only booking 4 women a month and supporting the birth for 3 women a month, you're able to give your very best to that person. You're far less likely to make mistakes, and you'll be working in a team that supports you, which will make you much happier, and you'll have autonomy. So therefore, both women and babies and midwives all benefit from working in this way. And that's the precious thing that I want to just remind us of today as we're thinking about continuity of care and rolling out our teams to encourage us to keep going. So thank you, Team Newcastle, for your work. And please carry on and let me know how you get on. And thanks for listening to this video. Bye.